And COVID has obviously accelerated this trend and pushed more of our lives online. And there's more and more investment in digital mental health settings, and not just in clinical settings, I should say. We're starting to see this in education settings, employment, social services, disability services, even in the way kind of insurance and criminal justice systems are engaging with this technology. And an example I came across just last week was my own superannuation company, which has about 680,000 members, and it offers a health platform that includes a reasonably complex digital mental health component. So I think when we talk about digital mental health technologies, we're talking about a really broad ecosystem of efforts to integrate long-standing, new and emerging technologies into the mental health context. So one simple way that I've found to kind of think about digital technologies is to just ask simply what it does and what its function is. And I've borrowed this typology, a way of categorizing, from health informatics, which is a sort of area of science that I had never come across until I started working on this. But I found it useful because it focuses on function, and I'm using material from Enrico Coiera. And these are some of the key functions that digital mental health technologies provide. They can be used for communication, for example, telehealth and online counselling, text-based support, information sharing, such as electronic health records, professional decision support, which I think was mentioned, so presenting information to clinicians, generating alerts and prompts, or in some cases making recommendations. Now, just as a point of kind of professional obligations, my understanding in a very general sense is wherever clinical decision-making support tools are used, the clinician ultimately holds responsible, or the practitioner ultimately holds responsible for the decision that is made. These tools may suggest courses of action, but it is ultimately responsibility of clinicians as a very general point. Digital therapies are another one, including apps, online programs, and increasingly AI-enabled tools. Personalised medicine, it's using data about genes and environment and behaviours of a person to sort of tailor interventions. And monitoring or surveillance, so tracking individual or population level information over time. And service user informatics, which are technologies that support people navigating services, making decisions, managing records, or accessing information. Any people out there who are on the NDIS, or if you're supporting clients on the NDIS, you'll know that there's a large sort of administrative burden that goes along with interacting with these kinds of systems. So there could be great value in service user informatics in that respect. Many technologies in these categories are already here, and you may be working with them. So this isn't really a conversation about the future, even though there are some areas of experimentation. It's really about what's happening now. And I want to be very clear about what the sort of overall scholarship says, and that's in my understanding of it, that there are genuine benefits associated with digital technologies, and they're not just hypothetical. Many have been demonstrated. Digital modalities can clearly break down geographic barriers, which is really important for our kind of communities in rural and remote areas. Provide support across large distances, facilitate confidential and anonymous help seeking, provide relatively inexpensive and accessible support, and improve access to information, facilitate social connection, support peer engagement, and assist with service monitoring and coordination. We don't often think about the technologies in that respect, but monitoring of services and so on can be greatly enhanced with the use of digital technologies. So it's not difficult to understand why practitioners and policymakers are often enthusiastic about these possibilities. And I think any serious discussion has to start with those kinds of acknowledgements of the benefits. Now, at this point, I want to introduce a theme that will run through my presentation, because one of the questions I've spent a lot of time thinking about in recent years is, well, what do people who are most impacted by this, people who use mental health service or have them imposed on them, or with experience of psychosis and so on, what do they want from digital mental health technologies? Now, this question sounds really obvious, probably to those of you who are familiar with the work of the Collaborative Centre. It's a relatively obvious question, but surprisingly it is not so much in this technological development sector, which frequently starts with asking what is technically feasible or what is commercially attractive in the case of the private sector, or what governments wish to procure. And only later does the diverse field of researchers and technologists ask what people really, what do they actually want? And I was able to demonstrate this empirically in some early research I did with a colleague, Timothy Kariotis, and we conducted a literature review surveying all applied scholarly studies that used automated decision systems or some AI data-driven approaches in online mental health interventions. And the findings, which are published in JMIR Mental Health, showed that the vast majority of applied research did not include people with lived experience. I'd ask you to guess, of the 132 studies that met our search criteria, obviously you don't know what our search criteria, but it was broadly applied studies. I'd like you to guess how many you think involved people with that lived experience in any substantial way. Well, it was actually only 3% that did. And we also found that there was scant consideration of ethical and legal implications of the proposed technologies. Now, I subsequently went on to do some consulting for the Wellcome Trust, as I mentioned, just a brief project. One of the most interesting findings from that review that I did with Ian Muchamore and Dr. Panos Karanikolas was how consistent some of the priorities of people with lived experience were. And just quickly, the review was commissioned by the Trust to examine what people with lived experience say they want from digital mental health technologies and how they've been involved in their design and development. And the review then informed Wellcome's big funding round on scalable digital mental health interventions. And the applicants were expected to then just demonstrate how they had meaningfully involved people with that service use experience. But interestingly, across the literature, people repeatedly emphasised three main things. First, it was enhancement and not replacement. People generally wanted technologies that complemented face-to-face support, perhaps unsurprising. And these are all generalisations, by the way. There are probably examples where people do want sort of, automated systems that don't involve face-to-face meetings. And second, trust was a really key issue, trustworthy design and operation, broadly concerning privacy, safety, security and accountability. And third, there was an interest in personalisation, accessibility and agency, because people wanted technologies that really supported their choice, connection and meaningful participation in care. And these priorities provide what I would argue is a kind of useful benchmark to keep in mind through the rest of the presentation. But they're certainly not without their complexities. So the point about privacy and data protection, for example, can be in tension with the push for personalisation. I've met people from services who have to grapple with this, including their peer or service user advisors. And that is because personalised digital mental health tools often rely on collecting and analysing more personal data to tailor support, while strong privacy protections may limit what information can be used, shared or even linked across services. So it's a good example of why for fuller discussion you often need computer scientists or engineers to sort of help explain the limits or trade-offs involved in designing technology one way or the other. But that said, a lot of my work has been premised on the idea that it shouldn't be necessarily computer scientists or technologies who are leading the conversation. It should be very much more a kind of collaboration and discussion, because I've sort of heard people in the field, whether as practitioners or service users, sort of say, well, I'm not an engineer, so I can't comment, or I'm not a computer scientist. Well, I think we could probably dispense with that idea, so that we can, in acknowledgement that this is a collective thing that is happening to the field and requires everyone to have a fair say over what's occurring. And as I've argued in my work, I think particularly people who are most affected by the services should be elevated in that discussion. So before moving on, I want to note these themes are not unique to our own research. Many of them are also reflected in the recent position paper of the AI and digital mental health technologies released by the National Mental Health Consumer Alliance. For those who don't know it, the Alliance is Australia's peak body representing mental health consumers. I actually advised the Alliance on the statement, though whether they took on my advice, I'm not clear, but I was asked to comment on an earlier draft, so I suppose I'm a bit biased, but I really think it is a thoughtful, balanced and very constructive statement. It very much acknowledges benefits, but emphasises some of the concerns and discusses issues such as sort of how to ensure the agency of consumers, just transparency, privacy and meaningful engagement, and the importance of ensuring these technologies support rather than undermine human relationships. So I'll come back to that document at the end if I have time, because I think it's a really interesting resource. And the other framework I'd briefly highlight that many of you will, I'm sure, be familiar with is the Digital Mental Health Standards developed by the Australian Commission on the Safety and Quality in Healthcare and released in 2020. They were designed to help digital mental health services get that kind of consistent levels of safety and quality. The standards are voluntary and accreditation is required for services receiving Commonwealth funding. So although it's voluntary, there is considerable influence because of that requirement on those services that receive funding. And many of the services that some people here may have used or which you may have recommended have likely been shaped by these standards, and I would argue they have been improved, because I really do see these standards as quite a globally significant policy innovation. You really haven't, you don't see government agencies in other countries being proactive in this way, or at least certainly not as early as the Commission did. And they undertook a national consultation that actively involved people who use services, as well as certainly practitioners, and their input really helped shape the standards. And importantly, one of the three major standards focuses on partnering with consumers. So it's a really good early example of global, internationally, of a government promoting consumer partnership. But right now, I'm going to try another Slido because I'd be really interested in your views. This is a word cloud, so I don't know if it works. Technology hasn't been kind to me this afternoon, so we'll see. But I'd like you to go in and answer the question, where do you think digital technologies can make the biggest positive difference in mental health? Let's see if it works. If someone can give me a thumbs up that they've tried putting something in, then I'll be able to tell you whether it's actually, and it should be working. But nothing's coming up, so maybe people are thinking about it. Oh, one participant's typing, that's a good sign. Rural and remote access to services, I think there's a lot of agreement about that. There's a virtual emergency ward program that my colleagues here at La Trobe helped develop, which has won a huge number of sort of health innovation awards and has been really helpful for people accessing emergency services remotely and reducing the pressure on those services. And I think we could understand why that could be extremely valuable in rural and remote areas. Able to support people between sessions, disadvantaged communities. These are all things that have come up. That's really helpful. After hours support, accessing cold communities. I mean, I'd be interested in that person elaborating at some point, but I suppose there's ways AI can be used for translation services and perhaps specific kind of technologies that could be used. Empowerment using self-help. Yeah. I mean, these are all reasonably common. Freeing up administrative burden is a major one. So I'll leave that and we can come back to it because I think that would be interesting. Young men's first contact, I think that's a really good point. People who've never had contact with the system, who may find digital avenues to accessing things, helping to navigate services. So I'll move on, but please continue to put your information in there because it will be interesting to follow up. And I'm concerned about time and I want to leave room for conversation. Now, if benefits are real, and it seems most people think they are, I certainly do, we also need to ask about harms. And one concept I've found useful comes from Joanna Redden and colleagues at the Data Justice Lab, and they use this term data harms to refer to situations where people end up worse off than they would have been had a particular activity not occurred. And one thing that struck me in my own research was how many examples of data harms were beginning to emerge in mental health services. Well, not services specifically, but contexts, as you'll see. Now, I don't want to spend the rest of the presentation giving a catalogue of disasters, but here's a few examples because it helps make abstract issues a bit more concrete. So one example that people may have heard about is BetterHelp. In 2023, BetterHelp was fined by the US Federal Trade Commission after it was found to have shared users' information with organisations including Facebook and TikTok, despite representations that information would remain private. So they told users that it would remain private, but they were sharing it with big platforms. Now, BetterHelp, as some of you may know, is a sort of Uber-style therapy where you can be connected, where individual platform users will be connected to therapists. And the company was required to pay $7.8 million US for deceiving consumers after promising to keep sensitive personal data private. In February, Joanna Kim at Duke University, this was in 2023, released a study on just how expansive the market for people's mental health or health data specifically had become. She found that data brokers online are marketing very sensitive data on individuals' mental health conditions, including what antidepressants people were taking, whether they struggled with insomnia or attention issues, and a range of medical ailments. There's been reporting on the targeting of sort of ADHD, sales of pharmaceuticals using online platforms in ways that potentially raise ethical and professional issues. Now, this is a useful example too because it demonstrates that digital mental health doesn't exist in isolation. You know, information gained in one context might move through a much broader digital ecosystem. And once that information starts moving, then you have questions about privacy, consent and discrimination and so on. And questions about who benefits from these data flows, and it's not always clear. Another example that's perhaps less of the kind of AI-related technology is in 2018 when Toronto police collated non-criminal information about individuals who'd self-harmed or attempted suicide. And seemingly it was a means to improve their interactions with those people and direct support to those who needed it. The information was circulated through police databases to US border authorities who then used it to deny several Canadians access or entry to the US. Another example was a 2023 major eating disorder support organisation in the US that attempted to replace human support staff with a chatbot powered by generative AI. It did not end well. The chatbot reportedly began providing dieting advice to people seeking support for eating disorders. And yeah, there are many lessons to be drawn from this, but one that interests me is how quickly enthusiasm for a technology can outpace careful reflection on appropriateness. And there have, of course, been multiple incidents where interactions with large language models or chatbots have been alleged to have been a contributing factor in a person's suicide or other fatal outcome. And there have been recent legal actions against AI companies that have over these incidents. And they've typically resulted in settlements, though some rulings have come down, and I won't go into the detail of that. But there's a question that you could ask about whether technology outpaces law, and I think this is generally a myth. So it's a myth that often appears, and it's this claim that technology outpaces law. Now, in many cases, this is just untrue. The BetterHelp example involved consumer protection enforcement. Privacy law is frequently applies. The Toronto police violated Canada's Privacy Act in that instance. And we could even look to things like robo-debt here of unlawful action that used automation technologies in social security. So more generally, anti-discrimination law applies, professional obligations apply, and I think I might sort of wind down my presentation so that people can start discussing these. I've got a lot more slides, but because we've run out of time, I will just sort of race through them. Now, clearly there are some novel legal issues, and I think the issue of chatbots engaging with people do raise novel legal issues, and you're starting to see legislators experimenting with ways to address these. So in 2024, California became the first US state to specifically regulate AI companion chatbots. I don't really like the term companion because it implies some kind of entity. And the legislation was motivated by the concerns about the emotional realism of AI systems and the potential for harm, particularly to children and young people. And it requires disclosure that a person is interacting with an AI, not a human being, requirements to implement safeguards concerning suicide and self-harm related content. How that's working, it's not clear. And it creates a legal pathway, importantly, for individuals to seek damages. Now, China has started these kind of laws as well, which have been specifically directed at what they call humanized or anthropomorphic AI systems. And I wouldn't be surprised if we see something like that. So whereas they don't refer to companion chatbots, they talk about anthropomorphizing computer software that mimics human beings or a sort of subject. So I won't go into detail there, but I think you can think about data harms not just at the individual level in terms of privacy breaches, incorrect predictions, discrimination and so on, but rather in terms of collective harms and societal harms. And I think practitioners in the mental health context have a great deal to contribute to those discussions about the collective and societal harms, and certainly, as I've argued a lot, so do the people most impacted, that is, people who are using services. I won't go into that detail, but if you are interested, I was part of a team who wrote a report for Mental Health Europe on artificial intelligence in mental health care. So I've given this definition of AI because I was going to talk a little bit more about AI, but I think I will actually just proceed so that we can have more of a discussion because we're running out of time. So instead of doing this, well, maybe while we're doing this, we can just have questions as well. But maybe while we are waiting for people to ask questions, others can jump into this Slido and answer the question, which concern about AI and digital technologies in mental health services deserves the greatest attention in your view?
Well, while people are doing that, Piers, we have got a couple of questions in Q&A. So jump in and add a question if you've got one, or pop your hand up and I will unmute you so you can ask Piers directly. Annalisa has said, would it be advised to run through a consent to discontinue, ask for further help at the beginning of every telehealth session as an ethical practice?
Can you repeat the question, Molly? I don't think I quite understand it.
Would it be advised to run through a consent to discontinue or ask for further help at the beginning of every telehealth session? I don't quite understand that either. And I must say, I think Annalise was the person who had to leave early for another meeting. So we can't get... I'll move on to the second question. Sure. Mika, do you want to put your hand up and I will unmute you? So Mika has said, we're quite confident in... allowed to talk, there we are. Quite confident in our context for what evidence-based platforms and apps we can recommend for young people, but would like to know what could be recommended for approved evidence-based positive AI tool companion for young people. Currently, we cannot safely recommend any AI tools, but young people will still use them regardless. So, Mika, you can speak. And
can you hear me okay?
Yes.
We can, Mika.
Yeah, awesome. I think my question sort of covers it, but in the text there that you've read out, thank you. Maybe now I've learned from this session that companion's not the best word. Anthropomorphic or M for AI sounds a lot more interesting and accurate. But yeah, it feels like it's so emergent that there's nothing yet that the evidence-based literature can come across and say, look, here are tools that are actually safer, thinking about harm reduction for young people and these sorts of tools, because there is use already. And what kind of conversations can we be having with, and the same would go for any adult consumers of mental health services, I'd imagine as well. I'm perfectly willing to accept there's no easy answer with this so far.
Yeah, thanks very much. Is it Micah?
Mika.
Mika, thanks so much, Mika. That's really interesting, and I feel for practitioners, whether peer support workers or people who are using mental health services, to navigate this issue. I can't imagine how challenging it would be if you do feel like there's no way to sort of safely recommend particular AI systems, yet you need to work with the fact that people are using these systems in their own lives. But I suspect that resources are coming thick and fast from practitioners who are, right at the cutting edge of researching these, providing some guidance to offer some salient warnings about these. But interestingly, in the position paper that I mentioned by the National Consumer Alliance, their members who informed the development of that position paper were really intent on acknowledging that people should have the dignity of risk in experimenting with these kinds of technologies. And that article that I mentioned by Sasha Brule also touches on this, that, it seems equally wrong to simply say you should not, you must not, you ought not engage with this at all, but rather to say, look, there are risks, let's talk about those risks, but, if you wish to and you want to and you're getting something positive out of it, well, who am I to sort of jump in and say that you ought not? But I think those issues around simulation and mimicry, things that at least I think, on an ethical basis, and speaking personally here, really should be stressed, because there is so much anthropomorphizing that goes on where people feel like there is a subject, a person, but these are disembodied, simulations of human encounters.
Thank you. Shane has a question for you as well. So Shane, do you want to jump up and ask?
Interesting to see safety as a kind of overarching concern in people. I suppose that captures quite a lot of those other issues as well. Maybe it's a sort of meta principle.
Shane, do you want to ask your question? Shane's typed into the chat but might not have a microphone. Will it be of benefit to carers or family in the future? Is anyone looking into this aspect?
Look, I suspect, technologies are vastly complex and multifaceted. Some will and some probably won't. I'd imagine some of the benefits that we see in other respects that we've been discussing, I mentioned around distance that people put in around remote access, will be of great value to family members who can connect with relevant services for them or maybe with their peers. But I just don't think it's possible to, generalize one way or the other. There are going to be those technologies that are probably quite helpful and some that have been applied or used in ways that might be negative in their lives. So I wish I could provide a pithy response there, Shane, but an interesting question. Thank you.
And I think with the benefit to carers and families, and I'm speaking as a carer of elderly parents here, there's so much in digital tools that are immensely useful to carers and families in terms of being easily able to access medical records and understand what's happened at latest medical appointments and being able to easily give permission. So it's not always just the therapeutic tools. There's a whole lot of other digital tools that are really useful, particularly for carers and family as well.
Yeah, certainly that administrative burden that I mentioned earlier is a very real thing for people who are supporting anyone, whether with issues of dementia or mental health crises or disability. And I do think technology can really assist there. The worry is, I suppose, that you just sort of intensify the amount of administrative materials that you need to then work with. But I think there'd be many families and carers who could attest to the value of not having to schlep all the way across a city and being able to join a Zoom.
Yes, definitely. I'm interested, Piers, see, you've done a bit of a scan of us with this Slido that we can see on the screen of the things that we're concerned about. From your perspective, in terms of, academically researching into this, are these actually the biggest concerns, or is bias and discrimination much more significant than we're giving it credit for here?
Look, I mean, what people have suggested here seems to check out with where most of the research is looking. And of course, safety is a broad category that, could mean so many different things, and privacy too. Australia is in the process of reforming privacy laws, but it doesn't appear to be happening in any substantial way under the current term of government. So I suspect maybe the next term of government we will see that. And I think those in the mental health context concerned about this should, join in the kind of broader efforts across society, because it's not something that is just unique to this sector, in order to sort of secure good and clear privacy arrangements in policy and practice. Bias and discrimination, I mean, I am interested in those things from perspective of Australia. I think we have done reasonably well to avoid some of the pitfalls seen in places like the US, because we have pretty available free public mental health arrangements. And I know that there are challenges with accessing it, but it means that people may not be as inclined to turn to private providers, and in ways that where their data could be used for things like insurance-related discrimination. So I don't see it happening in Australia as much as maybe at issue in other parts of the world. But certainly, issues of human connection, privacy and safety, these are all very prominent in the literature, and I would put them high in any kind of assessment of what issues are most important.
Piers, we're just about come to the end of our time. So I would like to invite everybody I'd like to thank you very much for coming along today, and invite everybody to give Piers a round of applause. It's been really fascinating to think about it from this perspective after the first 3 sessions that were much more from the practitioner perspective, and have a bit of a deep dive into the kinds of issues that we need to contemplate. And I've certainly taken down some ideas for further information for us as a group. So, for example, that consumer developed AI and digital mental health tool sounds really interesting. I think we should gather some more information about that. You can see if you can quickly fill out the poll so I can understand what you would like to learn more about. And then there is the evaluation form. I've written there C link in chat, and I should pull that up.
And maybe while you're doing that, Molly, I just want to thank everyone for bearing with me while the technical issues work through, and to say again that this is a reasonably high level account of things from a kind of international perspective. So I hope it has been useful. For anyone who's interested in more information, feel free to email me. I'm sure Molly can share those details at some point, or if not, they're freely available on the Trobe University website. And you shouldn't have much trouble finding some of the material that I referred to, but feel free to email me if you do and I can send it to you.